Welcome, everyone, and good evening to all of you, or good morning, wherever you might be in the world. As most of you know, that Thursday night in America is synonymous with high-class hand surgery education. It's much like Monday night football or Sunday night football. So Thursday night hand surgery is something that you should take for granted from AO North America. In keeping with the quality of education that we have provided you over the last several years, we have another fantastic session on Lalonde from Dr. Don Lalonde. And as you will see from his presentation, that it is just spectacular. But there are some facets of it which we need to be cognizant of and deliberative of. Therefore, this particular session will not be sent to you as a recording via Zoom right away. But once we have dotted all our I's and crossed all our T's, then it'll be accessible to you. So please hold your horses on accessing your recordings. And until then, you're going to have to enjoy this wonderful live session. With that, I'm going to hand it off to our moderator, par excellence, Sonu Jain. Sonu, all yours, buddy. Particular session.
So it's my pleasure to really introduce the master of this series for today, Professor Dr. Don Lalonde. As you can see, he's very decorated professor of surgery, past president of the Canadian Society of Surgery of the Hand, past chairman of the American Board of Plastic Surgery, past president of the American Association of Hand Surgery, past president of the Canadian Society of Plastic Surgeons, etc. And we also have a wonderful panel here as well. Moderating, I'm Sonu Jain from Ohio State. We have Peter Rhee from Mayo Clinic and Amanda Higgins, also from St. John, Canada at Horizon Health Network. And so here are the disclosures for the master and the panel. This is our agenda. CME credit is available. So just to remind everyone, put your microphones on mute. They've been muted already. And send your questions to the question and answer, not chat. So that's way we can review those and get them to Dr. Lalonde. And these are objectives. And this is session 10. We have a few more sessions left in the master series. And Dr. Mudgall already commented on this. And here we go. Without further ado, Dr. Lalonde.
Thank you so much. It's an honor and a privilege to be here this evening. Thank you for inviting me. And I'm going to talk about wide awake hand surgery, no tourniquet, no sedation in the hand, but also a few other applications, because I know that orthopedic surgeons don't always just do hand. There is a new edition of the Wide Awake Hand Surgery book with over 500 videos. I am the editor, but all the profits go to the Lean and Green effort, which is dedicated to less cost, less unnecessary cost, and less unnecessary garbage in hand surgery. I'm going to start by saying that there's nothing magical about the main operating room, and there's nothing magical about sterile saline. The magic is proper irrigation with effective anesthesia. And this is how I cleaned out this barnyard injury in a hand with a fractured metacarpal, exposed tendons, and skin loss. This patient never went to the operating room, but after proper anesthesia with tumescent local anesthesia, he was admitted, given IV antibiotics, and then we treated him with Vaseline and bandages. This is the days before VAC. Today he would have had a VAC, and it just healed secondarily, and he did just fine. Canadian tap water has 0 coliforms by law, and you don't need sterile saline. You can always wash things out with bottled water if you're in a place where the water is not trustable. This is a fight bite that I did myself on a Saturday night. I don't have resident coverage 3/4 of the time. And so I come in, and the first thing I do is draw all around the area of cellulitis. and inject local anesthesia. So I put 10 milliliters in the palm and block all of the common digital nerves. And then if you just look back here, you'll see that I've drawn the area of cellulitis. So I inject outside the zone of cellulitis, and I start proximally and then go radial and then ulnar and radial and ulnar. So all they feel is the first poke. And I put 40 milliliters in this blue zone that you see on the left, all around the area of cellulitis. So none of this hurts at all. And then after I inject the local anesthesia, I talk to the patient.
Until all of your pain is gone, none of this, and until you're on Advil, while you're on Advil Tylenol, you don't know what hurts.
So I let the anesthesia work a half an hour while I do the paperwork, and you can see extremely well without a tourniquet. You don't need a tourniquet. And what we do then is the most effective thing.
Right there. Straighten out your fingers again.
So I irrigate with Bridine and tap water, and I've been doing this for many years, and it's extremely effective.
Yeah, make it just again. So it's not hurting, right?
No.
Zero pain, right?
Zero pain.
And so tonight, when it starts to hurt, they're going to give you 800 of Advil. If that's not enough, they're going to give you a gram of Tylenol. And only if that's not enough are they going to give you something stronger.
He didn't need anything stronger. Most people just need Advil, Tylenol. You don't need opiates for this kind of stuff.
Hopefully not have to go that far.
And this is the morning after in hospital. So he never went to the operating room, never understood why you have to take pus to an operating room, especially for these minor abscesses. Sure, if you got neck fash, yeah, or an amputation, yeah. But for this little thing, oh, come on, give me a break. So he was admitted to the hospital today with COVID. He wouldn't even get that probably. He'd probably just get oral antibiotics with Keflex. Keflex is 90% absorbed compared to cefazolin blood levels. Anyway, there he is the morning after. All the swelling is gone. Why? Because he wasn't sedated. And I told him I wanted him to keep his hand up the whole night. And look at that. It's all, the swelling's all gone, which is pretty typical. And we built him a splint, and here he is 4 weeks after surgery. So for many years, fight bites have not gone to the operating room in my practice. And I was delighted to see a Philadelphia paper come out in 2020 showing that doing these in the main operating room is no better than doing them at the bedside, which is pretty much what I did. I do them in the emergency department. Now, this lady came in with a dog bite and definite flexor synovitis with pain on extension, fusiform swelling, pain on the flexor tendon sheath, cellulitis on the back, and there she is the day after surgery. I'm just going to pause. Whoever is not muted, can you please mute yourself? Can somebody mute yourself? Thank you. So here she is the morning after, just like you saw with the fellow with the fight bite. Just elevation, immobilization, and antibiotics. And of those things, what's the most important? Elevation and immobilization. Because if you don't tell them about that, they're pumping the germs around. And she had lymphangitis in the whole 9 yards. And here she is the morning after. Just ANSEF, elevation and immobilization, and pain-guided healing. Get them off painkillers and listen to their body and don't do stuff that hurts. You can actually see the little dog bite puncture mark that gave her the flexor synovitis. And here she is 8 weeks after admission. And for years, my colleagues and I have not been draining all of these, even though when I was a baby surgeon, I was taught, like most of you, that this is a surgical emergency. They all have to go to the operating room. You know, those rules that were written by Cannavale and Bunnell were invented in the 1930s. And that was just before penicillin was invented and available to the masses. And in the 1930s, if you got cellulitis, you died. So yeah, it was a surgical emergency back then. But many of these respond to oral antibiotic or to IV antibiotics, immobilization, and elevation. Having said that, some of them need drainage. So this one had pus. This was staph, even though that little thing is black there. And this is flexor synovitis with pus in the sheath. This one needed drainage. So I'm going to show you how I injected the local anesthesia distal to the transverse carpal ligament. This block, this is called a common digital block or tumescent local anesthesia common digital block, works much faster than a median nerve block. We published a paper showing that a median nerve block at the wrist takes 100 minutes to completely numb out the nerve. The bigger the nerve, the longer it takes to numb. And so if you go just distal to the transverse carpal ligament, that's a much more effective block in 30 minutes. In 30 minutes, you get a complete intense block. With a median nerve block at the wrist, in 100 minutes, you still get an incomplete block. And you guys have seen this all the time in the main operating room when anesthetists do proximal blocks, and you're still not numb. That's because they're big nerves. The bigger the nerve, the longer it takes for the lidocaine molecules to get to the center of the nerve. And so here we are.
Try not to move. It's going to be hard not to. Just do your best. So when I say go, I want you to take a deep breath, okay? So 1, go, deep breath. Great. You were great. You hardly moved a muscle. So I'm just supporting my 3 cc syringe with a 30 gauge needle with my thumb, so it's not wobbling. Can you please tell me when the sting is gone? Still hurting, huh?
No, not bad.
Not bad?
No,
I'm sure your hand is hurting like hell, isn't it?
hurting up around there.
Yeah, hurting up around there. Okay. So we just injected 3 cc's. Now we're going to put another 10. I don't think you're going to feel this. Did that hurt?
No.
Good.
So this fellow was 83 years old and bedridden. And so I couldn't walk him over to the sink like I prefer to do to wash these out rather than squirt 10 cc's of holy saline. But I still irrigated the hell out of it with Bridine and tap water and did that at the bedside. And first, I, of course, drained the pus in the palm and cultured it. And then, of course, had to drain it in the proximal phalanx. And then really used a huge amount of volume and squirted out all of the local, totally pain-free, totally washed him out. And then we admitted him. And he was in the floor for a while, and he did very well. Make sure that sheath is well washed out. You don't need to open the whole thing. That just causes a lot of scarring for nothing. And I've been doing this for years.
The most important rule from your point of view is to don't overroll. Because it's normal if somebody sticks a needle in you, you go like that. Then the needle comes out, I got to stick it back in. It's going to hurt 2 times. If you don't move, it just hurts 1 time. Are we good?
Yeah.
I'm going to count to 3. Before I do it. When I hit 3, that's when I'm going to put it in. That's when you try to not move. When I hit 2, I want you to take a nice deep breath. Okay, can you do that for me? All right. So I'm going to press firmly right here. So at the count of 3, try not to move. At the count of 2, take a nice deep breath. Are you ready?
Mm-hmm.
Okay, 1, take a deep breath right now and don't move. Great. Oh. You were amazing. That was fantastic. Are you always this good?
Sorry.
I know I'm pressing pretty hard there, and that's a little annoying. How sore is that right at this moment?
Not too bad.
Okay, you can just breathe normally now. How bad was that pain from 0 to 10, the needle pain?
Oh, it wasn't bad. One.
like a 1.
Yeah.
So I'm just going to add a little bit more freezing. You're not going to feel this one. Did you feel that?
No.
No, good.
I was doing a lot of talk anesthesia there because she's 20 years old and nervous as a cat on a tin roof. And
Okay, now we're going to let you bake like a cake for a while. So the one thing that you might feel is you might feel a little shaky because there's a little adrenaline in there. So if you feel like you've just seen a polar bear or you're ready to run the 100-yard dash, or don't worry about it. It's normal. You're not allergic to it. And the shaky adrenaline rush goes away all by itself in 15 or 20 minutes if you get it. So I'm going to come back in a little while. I need to see a few more patients. Then I'm going to come back and I'm going to put a little more freezing in the fingers themselves because they'll be pretty numb by then. Okay. I don't think this is going to hurt at all, but you're going to tell me if I'm lying. I don't think I am. Did that hurt at all?
Oh, if you did it, no.
so this is for the epinephrine effect. These fingers are already numb. And you can see I'm doing this in the middle of a busy clinic. So we did her surgery at the end of the clinic. We kind of tack the longer cases off to the end. Meanwhile, I'm seeing all kinds of other patients because all these have been done outside the main operating room for many years in our institution and in many places across Canada. So here she is at 4 days after surgery on the right with Amanda, and during the surgery on the left. So you can see that she's cut the tendons of 3 fingers, and we do up to half a fist of true active movement post-op. No more Kleinert rubber bands, no more full fist place and hold. And like many people, including Jinbo Tang throughout the world, getting much better results with this whole type of process. And you can see the Manchester short splint that Amanda's going to talk about again a little bit later. We don't immobilize the whole wrist anymore like we used to. And no more than half a fist, that's all you need to do. The main thing is you just don't want your tendons to get stuck, whether it's a flexor tendon repair or a finger fracture. You just want to move them a little bit, but not in the first 4 days. In the first 4 days, immobilization, elevation, let the swelling come down, let them get off painkillers so they can do pain-guided movement. Talk to them about painkillers during the surgery so that they are off everything on this first day of movement. Good. Great. Now straighten out. Right. All the way. Great. And we see there's 0 gapping. So that's a nice repair. That's not going anywhere. And we'll start moving it again on Friday. And between now and Friday, this hands-on strike. And then you're going to see Lisa on Friday. So walking around like this.
Okay.
No. Quiet, like a sleeping baby. Don't disturb it. Higher than your heart. So a great position is when you're at the kitchen table. Put your elbow on the table like your grandmother told you not to, and just because you want your hand higher than your heart most of the time. And what that's going to do is it's going to let the swelling come down. It's going to let the pain go away. And the work of flexion, in other words, how much work your tendon has to do so you don't rip it apart when you start moving. So what do you normally take for pain? Advil, Tylenol, nothing?
Nothing usually. Tylenol.
Okay, so you can go ahead and take Tylenol, no problem with that. Normally it takes about 5 or 6 hours for this freezing to come out. So when the freezing comes out and it's up higher than your heart, nice and quiet, and you get the sting of the cut that comes in, you can go ahead and take a little Tylenol. But probably by Wednesday, certainly by Thursday, the sting of the cut is going to be gone if you keep this up higher than your heart and you're not walking around like this and you're not moving. The sting of the cut will be gone. Once the sting of the cut is gone and you're into the pain of, gee, doctor, now it only hurts when I put my hand down or when I do stuff. That's when you quit taking the Tylenol or Advil altogether and listen to your body and don't do the stuff that hurts. We didn't spend 2 billion years evolving pain because it's bad for us. It's nature's only way for your body to say to you, hey, would you put that? I'm trying to heal in here and you're screwing it up. Stop that. And that's a little voice in your head you want to listen to, but you can't hear it with Advil or Tylenol in your ear. So that's why you quit taking that stuff by Thursday. And when you come in and see Lisa on Friday, you will have 0 Advil and 0 Tylenol in your body.
Okay.
And then you will do pain-guided healing. In other words, you just can't flex it if it hurts. Just listen to your body. But doing half a fist probably will not hurt because all the swelling's going to be gone. And if you don't do what hurts you, you won't get an infection in this finger. And if you don't do what hurts, you're not going to rip your tendon apart. When you start moving it on Friday, the rule is you can move it, but you can't use it.
Right.
Can you say after me, I can move it, but I can't use
I
it?
can move it, but I can't use it.
Say it again,
I
please.
can move it, but I can't use it.
Say it again, please.
I can move it, but I can't use it.
Perfect.
I can't stress enough how important this intraoperative education piece is. And that's why I really don't like sedation, because they can't remember a damn thing. And I give this type of intraoperative education to all my finger fractures, all my flexor tendon repairs. And of all the things that have decreased my complication rates over the years, this is it. The empowered, educated patient who walks out knowing how to take painkillers, knowing about immobilization and elevation to let the swelling come down and get off painkillers and do pain-guided healing. And one of my favorite questions during a flexor tendon repair is, so what were you planning to do this week? Oh, I was going to take my kids water sliding on Thursday. You're not going to be getting in the water on Thursday, I don't think, unless you want to screw up your tendon. Maybe we shouldn't bother fixing it. What do you think? You know, this changes their life. Having a flexor tendon cut changes their life, and you got to help them. And who better to help them than the surgeon talking to them about it during the surgery, instead of getting it in a pamphlet or a nurse telling them in recovery when they're stoned. So short incisions, Jinbo Tang has taught me about for less scarring. This repair was actually done by my resident. You can see that I've totally vented A4 and there's no clinically significant
Because
bow
the big
stringing.
problem here is that if you don't move at all, then the tendon gets stuck. And then you end up having another operation later called a tenolysis. We don't want to do that. If you move it too much, you're going to rip it apart. Because these stitches are only about 1/10 the strength of your tendon.
So you do this 10 times, so 9 more. So try to curl those fingers into that tuck position again, thinking about trying to curl the end joints down.
Nice.
Good.
I like to be there the first day that they move. Amanda's a great therapist and she's going to force them to move the DIP joint, but not everybody is as good as Amanda. And this is 3 months post-op. No clinically significant bowstringing in spite of the fact that the A4 pulley is vented, which I've done at least 50 times now. And it's just not a problem. And here's an example of complete venting of A2. No clinically significant bowstringing on the operating table, as you can see. Both tendons repaired. And you'll see at late follow-up, no clinically significant bowstringing later. But this early protected movement, this moving the DIP is critical. So here he is at 12 weeks, no clinically significant bowstringing. The whole A2, A4 thing was grossly overrated. It gave us 50 years of unnecessary tenolysis and rupture. And it's like a bad marriage. Let it go. The new rule is never vent more than a total of 1.5 to 2 centimeters of total pulley venting. Harold Kleinert wrote a really important paper in 1967 saying we can move fingers. This paper by Jinbo Tang in 2017 in Hand Clinics, I think, is just as important as Dr. Kleinert's paper. And it talks about this new rule. No more than a total of 1.5 to 2 centimeters. Why is there a range? Because long, skinny fingers, 2 centimeters. Short, fat fingers like mine would be 1.5 centimeters. The bottom line is just enough pulley venting so that your tendon repair doesn't get stuck. This is another important paper by Maria in 2016. 7 cases of complete A2 pulley venting, like the one I just showed you. 33 cases of partial A2 pulley venting. Not one case of clinically significant bowstringing. Is there a little bit of bowstringing? Yep, you can see it in the operating table. Does it cause a problem? Nope. That's why it's called clinically significant bowstringing. Bowstringing is not cancer. A little bit of bowstringing never killed anybody. And if you see bad bowstringing, the best way to do a pulley reconstruction is wide awake. And you can do it right then and there. So this is what we actually do. Here you see me cutting A4. And after I put my first sutures in, I do a full range of motion and I see if there's any remaining pulley that's impinging my repair. In this case, I'm going to cut those little cruciate fibers right there because they're impinging my repair. In this case, I can leave A3. You don't just whack everything out. You just take out incrementally what you need to so your repair goes from pulley to pulley and is not stuck. So here's another A4 vented, no clinically significant bowstringing at 3 months and no clinically significant bowstringing on the table. Another thing that I've learned from Jinbo Tang is that this repair on the left that's a little bit bulky is a good repair. I am embarrassed to say that I published the repair on the right, which is a terrible repair. That's the grandma kiss repair. So a grandma kiss repair is the 2 ends of the tendon are just touching, like kissing your grandmother on the cheek, just barely touching. And why did we do this for years? Trying to get underneath those damn A2 and A4 pulleys. Well, now that we don't have to worry about that, you can have a bulky repair that's not going to gap. The problem with grandma kiss repairs is that 7% of them gap. And here's a beautiful repair that I did in an FPL, patient's wide awake on her belly. And you see there's no gap. We haven't tested it yet. Now I want you to watch the gap that forms as soon as we test it. There it is. See where my little hand is? There's a gap. Now, if you got a motor block or a sedated, stoned patient, you can't see that. So they just go on and rupture 7% of the time after surgery. But this patient did not go on to rupture because we saw the gap at surgery and we fixed it. So how do you fix a gap at surgery? Here are the steps. First, don't remove the first loose suture. You don't want to beat up the tendon over and over again. You can use that first loose suture. The second thing is you put in a second suture that's tighter because the problem with your first one was it just wasn't tight enough. You thought it was, looked pretty when there were no forces of active flexion, but the forces of active flexion caused little bunching of the tendon in the suture. And that's when the gap appeared. So you put in a second tighter suture and leave the ends long when you tie the knot. Now you take those long ends of the second suture and tie that to the ends of the first loose suture after you tighten up the first loose suture, either by pulling on one of the loops or pulling the knot until it's as tight as it should have been the first time. And that's how you fix a loose suture that gaps. Here's another problem that used to happen when my patients were asleep or had a motor block. If you don't vent the pulleys properly, they rupture. I want to thank Peter Amadio for letting me share this image. So I'm going to show you a clinical case where this actually happened to me after a beautiful repair.
This is a 6-strand repair, and here's the second pulley. So we actually put the thumb through 2 pulleys, this one and this one. And now we're going to take the needle out. We're going to ask her to flex her thumb. Now it's very hard. Yeah, there you go. Do it slowly. Great. And straighten out. I was heartbroken to see my beautiful repair come apart with the hard pulley edge. The 6 strands were still there, but the tendon was flipped up. The pulley had actually pulled my repair apart. I'm going to show you that again with slow motion. There it comes down. You see the repair that's torn apart right there. You see the pulley come between the 2 ends of the tendon in my repair. This definitely would have caused a rupture, but we recognized it, cut the pulley, redid the repair, and did not rupture.
So in the old days of motor block, where you're not doing active flexion, you're just going to miss this kind of thing, and it's going to become a rupture. So full fist flexion and extension testing during Wallant permits us to recognize gaps, repair them so we don't have rupture. And it permits us to recognize any remaining pulleys that are blocking movement, and we can vent them so that we avoid tenolysis. And those, in the short time that Wallant has been accepted, the last survey a couple of years ago by American hand surgeons showed that 20% were doing their flexor tendons with Wallant. And I suspect that now it's probably at least 50%, because these advantages are so clear. I wouldn't ever consider doing a flexor tendon repair with a motor block again. I think I'd rather have nausea. And young surgeons all over are picking this up. This is Dr. Paul Valerie Roulette and his therapist, Jen Sager from North Carolina. I had the privilege of watching 7 or 8 beautiful results that they had, but they too have problems. They had one that got stuck at 6 weeks post-op. This patient did not get stuck. This one did well, but this one got stuck at 5 weeks post-op. This is another case. I had the privilege of presenting on a panel with them a few weekends ago, and they put this patient in this CMMS, this casting motion to mobilize stiffness. It's a therapy technique, and you can see at 5 weeks post-op, it's stuck. 4 days later with this cast, how much better movement they got. So CMMS is one way to get a FDP unstuck instead of tenolysis. Another way is relative motion splinting, and I'm going to show you an example of that. So in this case, there's A4 vented, wide awake, up to half a fist of true active movement. It's the long finger. And you see at 2 weeks, look at that beautiful DIP gliding in the long finger. And I'm thinking, oh boy, we got it made. Look at that. Isn't that pretty? But as often happens, it got stuck. And at 4 weeks, instead of panicking and going manic, I ultrasound these in the clinic. And I could see that the tendon repair was intact. It was just stuck. So we started relative motion extension splitting. It's like CMMS, but a little easier in some ways. And here you see 4 weeks after the relative motion splint, the splint taking the profundus out of scar. And so these relative motion splints or CMMS can decrease our tenolysis rates. And here he is at 2 years after surgery. So if your tendon gets stuck, check it out with ultrasound, then you know it. I think all hand surgeons ought to be doing ultrasound in their own clinics these days. I know it's really helped my practice. So in finishing flexor tendon repairs, short incisions, limited dissection, at least a 4-strand, very solid repair with 1 centimeter bites. I like Jin Botang's 6-strand repair. A bulky repair, judiciously venting up to 1.5 to 2 centimeters of pulley, including A2 or A4 if you have to. Intraoperative full fist flexion and extension testing with patient education, which is critical. Up to half a fist of true active movement starting at 3 to 5 days post-op. And relative motion extension splints, or CMMS, if your profundus gets stuck, as you see with ultrasound in the clinic. So the other thing that's gone the way of the dodo bird in my practice is 2-stage flexor tendon reconstruction with Hunter rods. So this patient had 4 fingers, all flexors cut with a machete in Honduras. And we harvested all 4 FDS tendons as grafts. And here's the critical slide here. Instead of doing a Hunter rod 2-stage, guess what? The A2 pulley is always there. So there's the distal end of the tendon. You look at this and all you see is scar, right? But underneath that scar, the A2 pulley is always there. So you take your scissors, your Stevens scissors, get right on the bone proximally, dig distally, get right on the bone distally to where you know A2 is, and dig proximally and build yourself a little tunnel between the bone and A2. And you can easily slide an FDS graft through there, which we did in all 4 fingers in this case. And there is the first finger. We didn't get our tension tight enough with the graft, so we put it in tighter. We got it right. And by the end of the case, we got all 4 fingers FDS grafts working. And we started early protected movement at 3 days after surgery. And here he is at 3.5 months post-op. I helped him with the therapy with WhatsApp from Canada to Honduras. And he did pretty well. So this patient is a rheumatoid who's got proliferative synovitis here in spite of being on all the biologics. And so I did a synovectomy and tendon transfer. And the first thing I do is draw with a pen 2 centimeters beyond anywhere I'm going to do any kind of possible dissection.
So at the count of 3, try not to move. You're going to feel a little poke. And at the count of 2, I want you to take a nice deep breath for me. Okay, so 1, take a deep breath and don't move. Great.
My favorite secret weapon is a 30-gauge half-inch needle on a 3cc syringe. And I like to push the skin into the needle instead of putting the needle into the skin. And I always pinch proximally and hold the pinch until the sting is gone. I do it in mid-inspiration. All these things create sensory noise. After my first syringe, I moved to a bigger syringe, 10 cc's with a 27 gauge needle, and finally end up with a 20 cc syringe on a short 25 needle.
And just breathe normally.
All she felt was the first poke. And even then,
How sore was that?
barely.
Actually, I barely felt it.
Well, that's good.
And I'm going to just speed that up so that you can see, but you always reinsert at least a centimeter inside tumescent tissue so they don't feel needle reinsertion. They just feel the first poke. And I inject on the radial side, then the ulnar side, then the radial side, then the ulnar side. And it's like seeing a big worm go underneath the skin. That's tumescent local anesthesia. That's enough local anesthesia that you can see it and feel it. And that's what Wallant is all about, tumescent local anesthesia.
Straighten out. See how your fingers are working pretty well there.
That's awesome. Thank you so much. It's awful when they're not working.
So the incision is buried monocryl. There's no nylon, no stitch marks, none of that foolishness. And go ahead and show us a fist again and straighten out. So for 3.5 weeks, that's excellent movement.
So we don't immobilize these for a month anymore. We start early protected movement because you can see with your Pulver-Taft weaves that they're so solid that in a reasonable, intelligent person like this, you can do early protected movement. And I'm just going to show you this, a part of this video by Amir Ahmad, who is from Malaysia. This surgeon is an amazing fellow. All this is done with Wallant. So this is a triple tendon transfer for radial nerve palsy, including pronator teres to ECRB.
Yes. Okay. Happy anyone, Changa? Very good.
And getting the tension right with tendon transfers is one of the great benefits of doing these with Wallant. You know, it's so easy to make these too tight or too loose, but if the patient's awake, you can get it just right. You can Google this. If you Google radial nerve tendon transfers and Ahmad, AHMAAD, it's in Global Open Access, PRS Global Open, and all the videos of how to inject the local and how to do the surgery are in there. For extensor tendons, we've been doing them with Wallant my whole career, but these relative motion extension splints have allowed us to measure intraoperative movement. So putting a patient in a relative motion extension splint after surgery allows them to use the finger 3 to 5 days after surgery and not rupture. The splints decrease the excursion and they decrease the tension. That's a relative motion extension splint for the index finger. When I learned surgery at McGill 38 years ago, we immobilized them for 4 weeks in a cast, and it's so much better to put them in these splints so that they can actually do things. This man was a workers' comp injury, and he worked on a fishing boat, and he went back to work 16 days after surgery with his splint on the boat. And in Canada, that's as a remarkable an event as it is in the United States. And here he is 7 months after the surgery with a full range of motion. There's just, it's such a good thing to do if you have not done it yet. And this is an anesthesiologist from England. He's a upper extremity block guy. He only does hand surgery as an anesthetist, and he uses Wallant all the time, but he really likes it for his ASA4 patients with high comorbidity, and here's why.
Rather than just having plan A and plan B, I'm able to have plan C and plan W, plan Wallant. They're extremely at high risk where they can't have a general anesthetic, they can't have a regional anesthetic, and they need something which I know is going to work and is going to be safe for them. So I think it really has helped me in those sort of circumstances where I think, well, I can't do plan A, can't do plan B, and then have to do Wallant. So it's made a big difference to my confidence in where I can apply the Wallant technique, the use of local anesthetic, the confidence of knowing that actually this technique really does work.
So it's a safety issue, and all anesthetists really should have this as part of their tool belt. Let me give you an example. This guy. So I did this fellow's carpal tunnel because he couldn't sleep at night. Now, this man had metastatic lung cancer when I met him. He slept sitting up on oxygen, and there's no way this man should have sedation. I mean, it's just not safe. And it's not necessary either. But he couldn't sleep at night. And doing his carpal tunnel enabled him to sleep at night for the last 6 months of his life. And I operated on him sitting up in my office with my headlight. On the left there, you're seeing his daughter stand up. She wanted to see the surgery, which I have no problem with. And she wrote me a beautiful letter after her father died, a nice handwritten letter, which you just don't get anymore these days. And she said, Dr. Lalonde, I just want to thank you on my father's behalf, because in the last 6 months of his life, after he fixed his carpal tunnel, his hand didn't wake him up at night anymore, and he was able to sleep in spite of having to use oxygen and all that. And we just want you to know that we're very grateful. And, you know, we hear that kind of stuff all the time. And I just never got, you don't establish a bond like that when patients are comatose. It's just such a lovely thing to do. You get to learn about people. Today, I learned all about beekeeping. Most serious complications of hand surgery are actually not complications of the surgery. They're complications of sedation. You know, pulmonary embolism and urinary retention and malignant hyperthermia and aspiration pneumonia, those aren't complications of surgery. Even if you just said, okay, let's not have any more nausea and vomiting. So we know that 7% of people who have sedation have nausea and vomiting. Just get rid of it. Like, you don't need any of it. And I remember when I was a young surgeon thinking that was inevitable. Now I look at it and go, oh my God, why would you give somebody that voluntarily? Amir Ahmad, this is the first wide awake distal radius plating that he published in the Journal of Hand Surgery. And the key to injecting long bones is not only under the skin, but you have to bathe the entire periosteum wherever you're going to put a plate. And so you walk the bone with the needle so that you bathe the entire periosteum. And if you do that, it's really quite easy to do pretty much any long bone. And here are 3 Americans, Jeff Gelfand, Paul Sibley, and Steve Kohler, and also surgeons from other countries. I've just picked a few. Taiwan, Colombia, England, people all over the planet are now doing distal radius fracture, especially in people with high medical comorbidities that you shouldn't put asleep. This is a transscaphoid perilunate dislocation by a couple of surgeons in France. So they reduce it and see the active movement, put in a K-wire, put in their screw, and see the movement with the screw in the scaphoid, and then K-wire the other joints and see the active movement with the K-wires in the other joints to see how stable they are. And this is the patient at 5 days after surgery, where they've started early protected movement. And the other hand happened to have a Bennett fracture that they put in a screw at the same time and also started early protected movement. There's the intraoperative movement, testing the stability of their fixation and the early protected movement. So seeing the stability of your fixation is really quite useful. It's also useful in arthritis surgery. This is Xavier Geffier, another French surgeon in another city. The first guys were from Paris. And this is doing a proximal row carpectomy with Wallant and then checking active movement at the time of surgery and seeing if any adjustments need to be made in what's cooking. This is elbow fracture surgery. It's the same principle with local anesthesia being injected, and then at the end of the procedure, testing active movement and looking at the fixation and making sure that it's appropriate. Last week, Dr. Alvarez from Venezuela put this new video on LinkedIn. Every week on LinkedIn, there are videos from all around the planet of surgeons who are using Wallant for various procedures. This is a radial head fracture, also from France, testing pronation, supination, flexion, extension after internal fixation at the end of the case. There's the pronation, supination under fluoroscopy in real time. This is a clavicle fracture. Most of these things have been published. Clavicle's been published. This is Chunyu Chen from Taiwan and looking at his fixation at the end of surgery. This is Amir Ahmad doing a patella fracture, bathing the patella all around with local anesthesia, testing his fixation at the end of surgery. This is a tibia fracture with plates and screws. Once again, testing the stability of the fixation. And a lot of these surgeons are doing earlier movement after their surgery, after testing their fixation. A number of foot and ankle surgeons have started using Wallant for all their foot and ankle surgery. And there the patient is once again testing the movement and the stability. And you can actually press on these things and see how stable they are during
Let's talk
surgery.
about what we're going to do for the next 3 weeks. Okay, slowly this time. And straighten out. Beautiful. And it's not going anywhere, so that's good. Does it look crooked to you? You can see better if I sit up. Yeah, go ahead, sit up. Can I take it out more? Yeah.
Do that a little bit.
Yeah. Okay, that's it. You only take it to pain, never past pain.
We do pain-guided early protected movement after almost all of our K-wired fingers. Now, just like flexor tendons, for the same reason. You don't want them to get stiff. You don't want them to get stuck. And this is a typical good result of early protected movement after K-wired fingers. And if they don't do what hurts, they don't get K-wire infections. And if they don't do what hurts, they don't take their fractures apart. Pain-guided healing, intraoperative education. Here is another example of a finger fracture with early protected movement, dorsal blocking K-wires, starting at 4 days after surgery. We saw with the intraoperative active movement that was stable, and there's the final result. Now, when it comes to doing these things, you don't want your patients to think you are a torturer. You would like them to think that you are a magician. And so you don't want to hurt people. So you want to aim for zero pain of injection of local anesthesia and zero pain of surgery. And I don't have time to go through all of the how to do that, but there was another beautiful review article that came out in August of 2021. And if you just Google Lalonde and PRS Global Open and local anesthesia, you're going to come to this video paper published in August with all kinds of videos of all of the 13 rules to follow to be a little bit magical when you inject the local and have your patients think that you're a bit of a magician. And here are the 13 rules. Small needles, don't blast it in quickly, slow down. Again, this article and chapter 5 in the new book has all videos for each one of these things. Buffer the acidic local with bicarbonate, insert the needle perpendicular to the skin, don't inject in the dermis, use sensory noise, blow in more than 2 cc's before moving the needle at all, never advance a sharp needle tip anywhere that's not numb, only reinsert needles in numb skin, inject too much volume instead of not enough volume always, ask for patient feedback every time, use filler cannulas for big areas, and always inject from proximal to distal. So if you look at that article, you too can be a bit of a magician when you inject your local. And if you do that, it really improves the patient experience. And so this is going to be my last slide. Just one moment here.
At the count of 3, you're going to feel a little poke.
Let's try that again.
At the count of 3, you're going to feel a little poke, and I'm going to ask you to try to not move, okay? 1, 2, little poke.
That was the worst.
And I really hate needles, just despise them. This needle was nothing, absolutely nothing. Kind of pressed on my hand 3 times, and then you put the needle in, and it wasn't uncomfortable. And then in a few seconds, it all went away.
I felt the first poke. It was not painful.
Not even a twinge, no discomfort whatsoever.
No discomfort whatsoever. There's a tiny, tiny prick, which is not even worth mentioning.
I didn't need to have any blood tests done. I didn't need to have the chest X-ray done.
No tests. I did not have to go in for tests, as opposed to waiting in line and having tests and then going back another day for surgery. I had to do none of that.
Why anybody want to go into a hospital and actually subject themselves to a pilot test and everything for no reason just makes no sense to me.
At the count of 3, you're gonna feel a little poke, and I'm gonna ask you to try to not move.
So I'm going to stop there, and I'm going to stop sharing my screen. And one of the best hand therapists in the world, Amanda Higgins, is going to start sharing her screen and give her talk. Amanda, would you share your screen?
Thank you, Don. All right.
I see it, Amanda. It's good.
Perfect. I'm going to start the slideshow.
You're good.
Great. So good evening, and thank you for inviting me to present on the topic of Lalonde. I've been working at the St. John Regional Hospital since 2003 with Dr. Lalonde and the other plastic surgeons. And so I've been exposed to Lalonde my entire hand therapy career. Wide awake surgery has been one of the most useful strategies in many of our hand therapy intervention programs because you can watch the anatomy move. Once a repair is finished, you can see how the repair site glides with active movement. Is the tendon bunching or catching on the sheath or pulley? Is there a gap in the repair? Is the repair too tight, preventing full range of motion? Lalonde allows us to detect potential problems that may result in tendon rupture or inefficient movement of the finger or hand. And these problems can be adjusted before the wound is closed. The patient is awake, alert, and comfortable, and this is ideal for starting the treatment process. What is going to lead us to excellent outcomes with regards to flexor tendon repairs is improved communication between surgeon and hand therapist. We are able to make decisions together about the treatment program, specifically when to start early active range of motion. 2 areas that Lalonde has had an influence on our treatment programs is flexor tendon repairs and the fracture management of hand bones. We have picked up some tips from colleagues around the world for our flexor tendon programs. Dr. Jinbo Tang and his colleagues in China have taught us that patients do not need to achieve full range of motion early in a flexor tendon repair program. So I don't use place and hold exercises. Patients are taught to actively move the tendon so that it does not get tuck and scar. But that doesn't mean that they have to make a full fist right away. Patients leave each session saying this mantra: I can move my fingers, but I can't use my hand. Dr. Fiona Peck and her colleagues from Manchester, United Kingdom, have taught us the Manchester short splint, and patients love it. The splint is still protecting the repaired tendon as MCP joints are positioned in 30 degrees of flexion to keep that flexor tendon in a slack position. But now you can do synergistic motion without even removing the splint. I have learned to try and get patients to initiate active motion at the DIP joint first. So the splint holds the MCP joints at 30 degrees flexion to protect the repair by placing that tendon in some slack. But it allows for initiating movement at that DIP joint. And this is what encourages differential glide. And this will help with the prevention of tendon adherence between FDP and FDS. So this is an example. This is a guy that lacerated his right long finger FDP at a zone 2 level. Right after surgery, I made him a thermoplastic dorsal block splint with MCP joints in 30 degrees of flexion, IP joints full extension, and wrist in slight extension. And he was taught to keep his hand at rest and to elevate the hand and asked to come back to see me in 4 days. So at day 4, I start early active motion exercises. Now the first or the top video is passive range of motion, inflection, and extension. And so this is our warm-up exercise. We don't want to start getting a tendon to move right away. So we want the joints, we want the patient to warm up the hand and the finger. But what you can see, what I'm getting the patient to do is with their other hand is block that MCP joint down into a little more flexion, especially when they go to extend. And this helps with PIP joint extension and trying to avoid those nasty PIP joint flexion contractures. The bottom video is the active tendon glide. So after they've warmed up their hand with passive extension and flexion exercises, then we start getting active movement going. And we call this a modified tuck position because those MCP joints are being held in a slight amount of flexion, 30 degrees, with our Manchester short splint. And we're encouraging that patient to try and lead this movement at the end of the finger, at the DIP joint. And so a quarter of a fist, a half a tuck position, as long as they're trying to achieve that by initiating that movement at the end of the finger, then we're happy. And the patient just keeps doing these same exercises every day for a long time. But around that end of the first week or that second week, we shorten their long dorsal block splint to this Manchester short splint. And that's key because then the wrist is freed up and patients can do a lot more when their hand and wrist is free. So then again, I touch base with them week 3, week 4, week 5. We keep working on the same exercises, the warm-up exercises, the active tendon gliding, and I just keep being a coach and educating the patient on tendon movement and encouraging them to try to get a little bit further in their movement until they can get full active flexion of that finger. These are some tips that I picked up from Gwen Van Strien, just some everyday activities just to try to encourage DIP joint flexion and movement at that DIP joint. So twisting a glass when they're enjoying a glass of wine or a beer, or scrunching up a tissue or a Kleenex or a towel, any kind of everyday activity that's available to them that's just a light activity to use. And then we discontinue our splint around that 5 or 6 week mark. So there's no more splinting after that. And then after that, it's just trying to encourage everyday use of the hand. We're also moving our finger fractures early too. The surgeon decides if the fractures need fixation with K-wires or not. If K-wires are required, they are only kept in until when you palpate, there's minimal pain. And usually this is around 2 weeks. So this is an example of a proximal phalanx fracture of an index finger. So the fracture was reduced and K-wires were applied. And the patient was made a protective splint. And this splint allowed early active motion at the end of the finger at the DIP joint. K-wires were removed at the 2 week mark. And so then we started, once the K-wires were out, we started removing the splint and showing the patient how to move PIP joint and MCP joint as well. At 4 weeks, we discontinue the splint altogether. And so the top video just shows the patient at the 4 week mark. And then they continue to come see me on a weekly or every 2 week basis for encouragement. And the bottom film is the same patient at 8 weeks. And usually this is when we end our therapy sessions. We are also moving spiral metacarpal fractures early. Again, the surgeon decides that the fracture needs to have fixation. The top film shows a patient who had metacarpal fractures of her long and her ring finger but she was very nervous to move, and she was worried about pain and worried about moving. And so the therapist who was working with her put this dorsal block splint on the top, and that encouraged her. She felt safe, and so she started moving, and she started moving at the end of her fingers, at the DIP joints. And then the bottom splint was a compromise. The bottom patient, he didn't have K-wires. He barely acknowledged that he had a fracture. We wanted to protect that fracture. So we worked with him, we compromised, and I made a splint that allowed him to still have most of his fingers free, but made me feel like he was going to have a really good outcome at the end. And so the end of the story is that for both tendon repairs, hand fractures, pretty much anything that comes and lands on my desk after they've seen a plastic surgeon.
So in my view, the fact that you're getting so much
we always encourage early active movement. We educate on pain-guided programming and getting people off of medications right away. And most of our programs are individualized based on what the patient wants to do and what the patient can do. Thank you for your attention. I'm going to stop sharing. All right.
Thanks, Amanda. That was great.
No, those were great talks. Thank you, Dr. Lalonde. Thank you, Amanda. Wonderful pearls. It's amazing to see the movement you started with wide awake hand surgery in the hand, moving up into the upper extremity and even the lower extremity. I think it's just really a testament to your work. And we have about 5 to 10 minutes for questions, and Dr. Peter Rhee will lead that. And Peter.
Thanks, Sonu. Don, that was awesome. And I remember when I first heard you talking about Walmart when I was a fellow over a decade ago, it was just mind-blowing. And so thank you very much for, again, kind of reiterating to us the importance of using wide awake. I really appreciated your addition to the talks now, incorporating the treatment of infections. My question to you is, with the pH changes around infection, and realizing that you have to get epinephrine to all the places you're going to dissect for hemostasis, how do you think it changes the total volume that you need to put in it? And other than getting a proximal nerve block, do you do anything different to get better hemostasis around your site of dissection?
Yeah, those are great questions, Peter. I think I try to not inject right in the area of inflammation, because that would really bloody hurt. Also, it would get washed out pretty quickly because it's inflamed. And that's why I inject outside and proximal to the area of dissection. In terms of visibility, for me, it really hasn't been a major thing, because most of the time when I'm doing this, it's really draining pus and washing it out. So it's not like I'm fixing anything or, K-wiring any fractures or anything like that. I'm just letting the pus out and washing it all out. And it's just made my life so much easier than in the days when I used to take them to the operating room. That was just annoying, especially on Friday night.
I'm impressed that you're taking primary call still. I think that you would warrant like 4 fellows and things ahead of you seeing them directly. That's great points. I really appreciate that. I think just logically, it seems like that patient with the fight bite at day 1, the marked decrease in the erythema was just incredible. I think I've never tried that in infections, but now I'm excited to try that on my next patient that has this problem. I was just curious. I think you have championed this and really taken it to the next level for all hand surgeons. Knowing what you know from when you first started, I think your journey and trying to let us all see the benefit of this. What do you think you've changed the most from when you first started with your enthusiasm? What have you found that you've kind of tempered your enthusiasm by not doing wide awake anymore? Or do you find that there's nothing you can't do wide awake?
No, I think I can't say that I have a long list of contraindications. I would not do wide awake surgery if I had no way to communicate with a patient. Like if I'm in another country and I don't have a decent interpreter, that's not a good plan. you got to at least have a decent interpreter. I think if people are psychologically unstable, people who are lost in space, for example, you got to be able to reason with people. Even kids are fine, as long as they're not off the wall kids. Like if they're good kids that you can reason with and get them to pay attention and they don't get lost in emotion, then they're great. And I think probably the thing that I've changed the most over the years is the intraoperative education piece and the pain-guided healing piece. And the early protected movement with K-wired finger fractures piece. Those pieces have just made, Amanda showed it so nicely. It's just made things so much better and our results so much better. So I think those are the things that I've probably changed the most.
Thank you. It's always so nice to hear you speak. I always learn so much, and even concepts that I thought I understood, you clarify so nicely with your illustrations and case examples. There's a question for Amanda. Amanda, we noted that in a lot of your patients, you have a co-band around the finger for edema control. But they're still doing a lot of their therapy and motion with the co-band on. And the question is, does that add too much to the external resistance that the tendon sees if you're putting the co-band around the fingers?
You know what? Every time I present, I get this question, and I've been presenting a long time. And the answer to that is, I don't have any issues with co-band. I certainly don't. It's not on tight. It's it's wrapped circumferentially down the finger, and it's not on snug. It's on so that it doesn't fall off, kind of thing. And as people are doing their movement, it does bunch a little bit, but I've never had an issue with it, and none of my patients have ever had an issue with it. I've tried to do exercises with people without it, because a few times people have asked me about this question. So then I go back, and people with big swollen digits have just as much bulkiness and just as much problem trying to move fingers. So I don't find it to be a problem at all, and I haven't had any issues with it.
I'd like to chime in on that one if I could, because I've heard that too. And so I actually looked up the source of this, and for me, this ranks right up there with you can't put adrenaline in a finger. So there was one paper in a cadaver where they did one cadaver hand and wrapped it with Coban and measured the work of flexion. And they injected saline, it was just, give me a break. It's just so unreal in terms of the normal situation where you got blood in a finger and a live finger. Cadavers are not live fingers, okay? They're just not. That's where a big part of this A2 and A4 pulley stuff came from. Cadaver work. Cadaver fingers are not alive. They don't have blood going through them and all this kind of stuff. And you're certainly not going to tell me that what you measure in a cadaver for work of flexion actually means anything compared to in the live patient. If you did wide awake measurement of work of flexion, then I'd believe you. But I really don't think that wrapping a finger with Coban matters at all, except for it takes the swelling out and makes less work of flexion. And that's a good thing. And, Amanda and I have flirted with, okay, well, let's do what all these people are saying. Let's take off the Coban for their exercises. Nobody's going to take off their Coban every hour and put their Coban back on every hour. They're just not going to exercise. So let it go.
And most patients come back and they say, I prefer to wear it because it feels better. It feels like there's something helping to control the swelling in the finger. And I think another point, Dr. Lalonde, thank you, is that we're not getting people to force their fingers down. It should never be that you're doing exercise that is forceful. It's still within a tolerance. It's still within whatever that resistance is. And so if there is a resistance with Coban, patients, when we educate them, they understand, just move your tendon, we don't want you to do anything that causes pain or that's forceful. And so as the swelling moves out and as that tendon finds its path through that scar and through its new journey, things seem to work out and it seems to be fine.
Right. Just don't get stuck.
Thank you. I think I have one last question from Warren Hammert, who had a really good question, which is, I think for most people, if they're concerned about, prior vascular injury or they have scleroderma, something where they have known peripheral arterial disease or borderline critical ischemia in the finger, you probably shouldn't or have a lot of caution doing wide awake epinephrine in the finger. But what about those patients that say, yeah, I get Raynaud's type, either syndrome or kind of phenomenon? Does that give you pause at all if they don't have a known systemic vascular problem, but they just say, yeah, I have Raynaud's? Does that make you not do it, or at least inject phentolamine afterwards or something?
Right. That's a great question. Thanks for that, Warren. And I think that the key to all of this is never be afraid to inject phentolamine. Just do it. Like if you haven't injected phentolamine yet and you're doing Wallant, what are you waiting for? Just do it. And then as soon as you inject phentolamine once and you see the finger go pink in half an hour in everybody, you're never going to worry about this stuff again. Having said that, there's no point in flirting with razor blades, okay? So if somebody comes in and they barely have 3 red cells going through their fingertips, why would you inject adrenaline in the first place? You can probably just inject lidocaine and operate on them. They're not even going to bleed. So, and you can decrease your concentration to 1 in a million, like Teddy Prasetyono does in Indonesia. But I think the main thing, just inject phentolamine. We all ought to be injecting phentolamine with accidental EpiPen injections in the emergency department anyway, not because the fingers die, but to prevent ischemic reperfusion pain, which can be significant for nothing, and to prevent ischemic axonotmesis, which can happen as well. So just get used to phentolamine, use it. And even people with Raynaud's, it's not going to be that big a problem. I have injected people with Raynaud's, and interestingly, I remember one lady very well. She had a trigger finger. I injected it with lidocaine with adrenaline. And after I injected, she said, oh, by the way, I got terrible Raynaud's. And I went, oh, okay. So I'm ready to pull out my phentolamine. And what happened was she got a sympathectomy in the long finger that I injected, and that one was red hot because of the sympathectomy. The lidocaine only works where you put it in, right? The other fingers were blue. The one I injected was red hot. So you do get a distal sympathectomy, but when in doubt, phentolamine it out. That's it.
That's great. No, thank you so much. Sonu, I think that we're probably at the 7:15 mark, or where I am.
I think we have time for maybe one more question, I think, and then we'll probably, is there any other ones on there, Peter, that you want to ask Dr. Lalonde before we conclude?
No, I think we've answered most of them real time, unless the faculty have any questions.
That was great. What a wonderful discussion. I think we could literally go on for another hour or two, just literally picking your brains on how to do this, what else can we do, where can we take this, and how do we make them better, post-operatively. But such a wonderful discussion. Thank you so much, Dr. Lalonde, Amanda, Peter, thank you for running the show afterwards. And thank you, Dr. Mudgal. I know you want to have a couple final words to say. Thank you for putting the series together.
Thanks very much, guys. One of the beauties of having a series like this is we call it the master class. And the reason we've called it a master class is because we feature people like Dr. Lalonde and Amanda who have reached a level of expertise that all of us want to aspire to. So there is a temptation to emulate what they are doing while forgetting the steps that they took to teach or reach this level of experience. So in as much as all of you watching out there and listening out there want to be like Don, it's like or like Amanda, like that old Nike commercial, be like Mike. Don't think that you're going to be there in 10 seconds. You're going to have to put in the hard graft. You're going to have the infrastructure. You're going to have a supremely talented therapist. And only then are your results going to look like that. So just be careful of that. And I think I need to say that because these are spectacular results, but they haven't come overnight. They've come in with years of work. So with that being said, thanks very much. That was spectacular and something that we can only aspire to. So we will meet again in 2 weeks. Sonu, Peter, Amanda, and Don, thanks so much. Good night, everybody.
Thank you.